All right, hello everyone, and welcome to Tobacco Cessation Counseling Clinical Best Practices and Introduction. Before we begin, I just want to cover a few bits of housekeeping. First, if you are using your phone's audio, please turn off or mute your computer's speakers. Perhaps most importantly, please mute your phone by dialing *6*. The star needs to be on both sides of that 6. We are expecting over 100 participants today, and this line may get very noisy, very fast. So as a courtesy to your fellow audience members, go ahead and just dial *6* right now. Although we do not expect any technical problems, you may want to copy the link shown here. If you are disconnected, you can use this link to rapidly reconnect. Alternatively, keep the confirmation email you received handy and use the link that's in there. If you have any other technical issues, please contact our administrative assistant, Sarah Mumby, at the number shown here, area code 303-724-6327. I'm Jim Pavlik, the Program and Policy Analyst at the Behavioral Health and Wellness Program and the Build a Clinic Learning Community Program Manager. I've worked in public health and policy for 10 years in various capacities, including physical activity promotion for the Indiana Department of Health and emergency preparedness and response for the U.S. Department of Health and Human Services. Currently, I perform program evaluation for BHWP and its partners and clients, and I'm also one of its lead trainers with a focus on organizational tobacco control programs and technical assistance. Our presenter today, Dr. Chad Morris, is the director of the Behavioral Health and Wellness Program at the University of Colorado Anschutz Medical Campus and associate professor at the University of Colorado Department of Psychiatry. He's a leading expert across a range of behavioral health-related areas and a nationally recognized authority on the study and treatment of nicotine dependence, especially for the behavioral health community. For the last several years, Dr. Morris has been a leading advocate for the integration of behavioral and medical care and has served in various capacities to further that goal as a consultant, academic, principal investigator, and educator. Today's presentation is the first in a 6-module series covering the knowledge and skills practices need to know to efficiently and effectively integrate tobacco cessation services and supports into their current clinical workflows, with a special emphasis on serving rural or otherwise underserved populations. These webinars will take place monthly. In the second webinar, we will discuss pharmacotherapy options. Combined with today's presentation, these 2 companion presentations provide the basic skills necessary to begin treating nicotine dependence right away. For the third webinar, we return to counseling with an in-depth look at the use of motivational interviewing within the 5 A's framework, which we will introduce today, with a special emphasis on advancing clients through the stages of change within a single counseling session. After that, we will discuss workflow and how tobacco cessation fits into a typical clinical workflow to find low-burden ways to integrate tobacco cessation interventions into existing practice. In the 5th month, we introduce the whys and hows of tailoring tobacco cessation interventions for populations specifically targeted by the tobacco industry, and those populations that, although maybe not specifically targeted, tend to lack the preponderance of services that frequently lead to more successful quit attempts. This presentation will focus on cultural sensitivity and how the use of motivational interviewing can make clinicians more adaptive in the face of our increasingly more diverse and ever-shifting populations. Finally, we will look at the internal and external resources that can be brought to bear on this new program so as to create a sustainable culture of wellness. Thank you again, and with that, I will turn it over to Chad, and afterward we will open up the lines for Q&A.
Great. Thanks, Jim. And again, welcome everyone. Thanks for joining us today in the first of this series in the Build a Clinic program. And so just to go over briefly our objectives for today, and again, I want to talk I'll probably talk about 40 more minutes or so, and hopefully then have plenty of time for Q&A. But really what we want to do is just set the foundation for the series as a whole. And today focus on some low burden methods of screening, for advising folks to quit smoking, for how do you start to look at and consider assessing, and assisting and arranging treatment within your busy practices. And what we'll be doing, as Jim mentioned, through the series of modules, is that what we're really presenting today is the framework and the evidence-based framework that's used in a variety of settings for integrating tobacco cessation into daily practices. And then we're going to really circle back and get much more in depth in some of these areas. And I'll point that out as we're moving through some of these screens. So just to introduce this whole topic, and some of you might have seen these slides previously. We've smoking in general has been an incredible. What we've done with smoking cessation has been an incredible public health victory. Maybe potentially one of the best that we've done nationally. And you see the rates of trends of smoking among the adult population in the United States, with the green on top, which is the men, and the blue on the bottom, which is the women. And just see from the 1950s, I call that the Mad Men era, when for those of you who watched that show, and where smoking was incredibly prevalent and everywhere you went. Over half of the population, if you were a man, smoked at that point in time. Over time, you see the trends decreasing. Really, men and women came together. That's for a variety of marketing and targeting women in the 70s and 80s. You see the gender gap close, but fortunately, both of the lines are decreasing. So right now, we're at about 17.8% of adults are current smokers in the United States. But the bottom line for the work we're doing with Build a Clinic is that for at-risk populations, we haven't seen these gains at all. So for a variety of at-risk populations that you see in your clinics, whether it's a primary care clinic or an integrated care clinic or behavioral health clinic, hospital settings, at-risk populations are still smoking at 2 to 3 times the rate of the general population. So, you can just triple, double, or even triple that 18% that I was talking about. So these are individuals with behavioral health conditions, both on the mental health side and in addictions. This is a low SES issue in general, if we really want to frame it that way. Justice-involved individuals, that are suffering chronic care conditions, the LGBT community, armed services, and I'm missing a few, but that gives you the point that there's a lot of populations that are smoking at very high rates. And these are the individuals that you're seeing in your clinics. So just taking the behavioral health population, as many of you are well aware, on the low end, probably 40% of your patients have some kind of behavioral health condition. So they're much more at risk. And those folks are also suffering if they have a behavioral health condition. They're typically grappling with 2 or 3 different chronic care conditions on top of that. So they're at multiplicative risk for smoking. And so this is really what we're targeting. And fortunately, there's a really strong and growing evidence base that we can really impact this trend and help these individuals quit smoking, and really do that in a way that's low burden to, again, very busy practices with lots of competing demands, and really look at how can we integrate this into your daily practice in a way that makes sense. And so that's what we're going to start discussing today. It's very clear that based on what I just said, and we're losing in the United States, we're losing 480,000 individuals on the low end to tobacco use that are dying on an annual basis. There's a new study that came out that said that rate is probably closer to 520,000 folks a year in the United States, and that's not even counting the individuals dying due to secondhand smoke exposure. That's about 20,000 more. Huge, huge issue. And so tobacco use, even though we're spending a lot of emphasizing obesity and so forth in the U.S., which we should, and other health conditions, tobacco is still the leading cause of preventable death in the United States. So many of you have seen this triple aim if you're in the healthcare field, the triple aim philosophy of how do we really provide better quality care, how do we do that at lower costs over time, and how is that going to end in better population health outcomes. And so there's a very compelling case to be made that the best way to do this is to address tobacco. And hopefully many of you are on the phone because you believe that. And if not, we can provide more evidence, but I'm hoping that that's exactly why you signed up for this series in the Build a Clinic. We know tobacco has, when we treat it, it has 2 parts. And so we have to talk about both the physical side of the nicotine addiction as well as the behavior change that needs to happen if we're going to address this. So this is really what we use at the Behavioral Health and Wellness Program is chronic care modeling, and we use chronic care modeling because it's familiar to most practices out there. But really, tobacco use is a chronic care condition. So it's a chronic relapsing condition. And just like whether we were discussing asthma or diabetes or something similar, you really do need that combination of looking at the medication treatments. That one of our presentations will be focused on the pharmacotherapy presentation that's in our series. And then you also have to focus on the behavior strategies. So we're going to talk about the foundation of more of the behavior strategies today, and we're going to get much more in depth in that with the motivational interviewing um, module that we'll be doing. We'll be doing, looking at special populations, etc. And then on the medication side, we'll be looking at the FDA-approved medications and how do you really insert that into your daily practice as well. So we know, unfortunately, most individuals out there that are smokers are still quitting unaided or cold turkey. So that's the majority of folks out there. That's how they're trying to do it. Unfortunately, they're not real successful. You see that if you're going to try to quit unaided with no help, your rate of success is going to be it's probably closer to 4%, even though we give that range of 4 to 7%. I've heard more like 3 to 5%, for instance. And so you'll always hear that. And there are people that definitely are able to quit unaided and just do it on their own. Really, one of the first questions you should ask folks when they say that is how many times did you have to try or attempt to actually achieve abstinence? And it's probably going to be a pretty high number. We know that if folks are smokers or nicotine users receive help, whether counseling or medications, they're going to be incredibly much more successful. So if you look across just and self-help as well, they can get the self-help, but if they're going to the quit line, and we're going to talk more about the telephonic services that quit lines offer. If you're looking at just the counseling side of quit line or individual counseling at your site, or you're referring out to another site or group counseling, that's going to pop that up. That's going to at least triple that rate of being abstinent and being able to quit smoking or other nicotine products. That said, medication alone, nicotine replacement therapy or other FDA-approved medications out there, which we have 7, that alone can pop up the cessation rates as high as 22%. But again, just like other chronic care conditions, if we're able to mix that medication with the counseling, that's going to be the biggest bang for your buck, and you're going to get rates really high. 25, 30% is very common. And in some cases, you're going to get higher than that. There's some controversy around something like Chantix or varenicline, but why people are so interested in that is that even varenicline with minimal counseling, we're seeing rates as high as 44%, for instance. So that's why even with the black box warning for that, we're very interested in new medications like that. So, but just to kind of paint the picture again, treatment works. There are ways that we can insert this into our clinics and really play a key role in helping people really quit what is one of the hardest addictions, if not the hardest addiction to quit. But part of the framework out there and that you are very much well aware of that fits into helping folks quit smoking are a few things. One are just the regulatory requirements right now that it really doesn't matter what kind of healthcare setting you're in. You're going to have to provide some kind of some degree of tobacco cessation treatment. It really doesn't matter where you're at this point. And I think that's going to increase fairly dramatically over time. So even if you're in a behavioral health setting alone, not an integrated care setting, meaning a primary care and behavioral health setting, we're seeing that's probably going to move towards the same standards that would be required for primary care. So for a lot of you out there, say you're a primary care clinic, a lot of you might operate under HRSA standards, and tobacco is very much piece of the reporting requirements under the Uniform Data System that HRSA requires if you're an FQHC or federally qualified healthcare clinic, or other funding from HRSA also requires that. And so what that means, just as an example for HRSA, is you need to be both screening for tobacco and treating it. And treating can involve referral, so that counts as treating as well. But again, the point is, this is where we're headed. So if you're joining this, you're trying to build this into your clinic, you're just getting ahead of the game, or really getting up to speed with the Accountable Care Act that we're going to talk about next, the Affordable Care Act, excuse me. Because this has really been expected for some time, and this is going to speed up across the next few years. So really the essential health benefit under the Affordable Care Act, whether you're an expansion state, you're part of the market, or so forth, this is tobacco screening and treatment is part of the essential health benefit. And there's not, just to be blunt, there's not been a lot of monitoring about this right now, but I think that that is actually also going to increase fairly dramatically in the coming years. So what does that mean? What is the essential health benefit when we're talking about tobacco? And you can go two directions with this, really. If you're a mental health or substance abuse agency, it might be rolled into the services as far as your contracting at the state level for providing those services, because with the new DSM, the DSM-5, tobacco dependence is on par with the other addictions, and so under parity and so forth, you might mental health parity, you might include that on that level. Outside of that, a lot of the other sites in primary care and so forth, it really falls under the preventive and wellness services. So for any essential health benefits, so we're talking about expansion states or the marketplace or third-party payers, this is really the standard of what you need to offer. So it's at least 2 attempts per year for counseling sessions per attempt. So that can be a lot of things. Again, that could be the quit line telephonically. That could be individual counseling. That could be group counseling. 90 days of FDA-approved medication, no cost sharing, and no prior authorization. So that's really what's, to meet the criteria right now for the essential health benefit, that's what all these players are going to have to demonstrate as outcomes. And then, of course, with meaningful use, too, for those of you that have been very much wrapped up in this in the last few years, or you're getting your EHR or electronic medical system set up, this meaningful use tobacco is very much a part of meaningful use, both on the meaningful use side, which means you need to be screening for it, but also tobacco is one of the core quality measures. So meaningful use really refers to the screening component, and the core quality measures refer to the fact that once you screen, you actually have to do something with it. So you actually have to either refer out or at least offer brief treatment. And so that's kind of, and also under Medicaid, just to mention that briefly, almost every state right now, there is a pretty good Medicaid benefit. And so a lot of your clients, of course, would fall under Medicaid and Medicare. And so Medicaid and Medicare, a lot of patients specifically, and a lot of clinicians aren't aware how fully their states cover Medicaid. And I believe we'll get into that more also in one of our future modules. So let's talk then again, that was the setup part of the presentation. Now I really want to get into, well, what is the foundation for change that we use across multiple settings? And so we've worked in criminal justice, primary care, hospitals, behavioral health, homeless settings, pregnant moms, perinatal moms. And so the foundation is really the same across all of those different settings. And we refer to that as both the 5 A's and 2 A's in our model. And so on the 5 A's side of the equation, on your left-hand side of your screen, and we're going to specifically go through these steps. It's asking about tobacco, it's advising not to use tobacco, it's assessing use and dependence, it's assisting folks to get help, it's arranging follow-up to that. And then there's a truncated version of that too that's called the 2 A's in R model. So that's ask, advise, and refer, and we're going to talk about that as well, because for some very busy practices, they might be able to just do the Ask, Advise, Refer, and that has a huge impact in itself. But we really hope to get, through the Build a Clinic program, help to get folks using all the full 5As to the degree that they're able, given their resources and your staffing. So starting with Ask, so the first of the 5As. This is incredibly important. So ask all individuals about tobacco use. So somehow getting this into your screening, into your paperwork at entry, and then following up on it. But basically, the primary provider asking, do you or does anyone else in your household use tobacco? That does anyone else in your household use tobacco is a very important piece of this, because that has huge impacts on your patients as well, if they have that secondhand smoke, or it has implications for them being able to quit their tobacco use if they're around other smokers. You might ask, how many times have you tried to quit, just to kind of start to get that rapport going, and explore tobacco use history. We're gonna do much more of that in some of the next steps as well. But asking, we've done a fairly good job in the healthcare field in general in asking, and so a lot of this is being driven by our electronic medical records, our electronic health records, and really looking at how we're integrating this in the standard practice. So what we want to get to is assessing tobacco as part of normal assessment and screening, and then adding tobacco cessation to the ongoing treatment plan. And so most EHRs, because they should be aligned with meaningful use and other data reporting that's mandatory for whatever structure you have at your clinic, you should be capturing this. In the old days, when I say that, 6 to 10 years ago, the easiest way to do that was just to include it in your vitals. So if you're looking at blood pressure or pulse or weight or height, you just add the tobacco use question that you see on the right-hand side in that box. But now you really want to make sure that what you're asking is aligned with your payment structure and so forth in your EHRs. And again, we're going to get more into that in some of our future modules as far as sustainability and workflow. But we just want to make sure that that's kind of getting out there. So most folks are doing a really decent job of asking, but historically what happened is often that's where everything stopped, particularly in a state system. So we would stop at asking. We would ask something like, do you smoke? Yes, no. And then we didn't do anything with the information. And so we've actually gotten better in that regard, in that most sites are now pretty adept at advising too. So you not only want to ask about smoking, but you want to advise people to quit in a clear, personalized, and non-judgmental manner. I mean, you are the ones that have the rapport with your patients, and so it's really just using that rapport to say, basically, I care enough about you as a physician, and this is such a critical issue for your health that I'm advising you to quit smoking in whatever way you're going to say that. And so we're going to get into, again, some of those strategies when you're advising, even around the motivational strategies, motivational interviewing strategies about how to do this. But you really want to get at what would motivate this person to quit. And you can ask some clarifying questions and so forth, but that's the main point. And if you just do those two things alone, okay, ask and advise, and you are on that right-hand side of this table, you see a physician and clinician, and even the non-physician clinician in your workflow and in your team structure, you can as much as double cessation rates just by these two steps alone. So we're talking about maybe a minute, 2 minutes of time, something like that, and it has huge impact. So just these two steps alone are very, very critical. But we can do better than that too. And we're going to talk about the other of the 5As. But if you're a clinic, and this is completely understandable, we know how many competing demands so many of you face out there. So at the very least, if you can ask, advise, and the asking part really is, again, you're creating that registry, you're building it into the treatment planning, you're advising your patients to quit smoking, and at the very least, what you want to do is you want to refer and make sure that your referrals are quality. And so that could be a tobacco-free group out in the community with one of your partners in the community. It could be more in-house in some respects. It could be the quit line or helpline. That's a very common one that we're going to talk about. But if you can do that at least and document it, it's going to have huge impact on those you're trying to serve. One point I'd like to make too is, and I didn't mention this, but it is important to note, is that when I was talking about asking, so the first of the 5 A's, it's important to ask at every visit. And that can sound like a broken record, and often we get feedback from providers saying, really, are you really telling me that I should ask folks every time they come in? Aren't they going to get sick of it, etc.? And what we found is that's really where you have your impact. And it's essentially the same as if you were talking about weight management. Or as an analogy, if someone was coming in, they're seriously obese, you're not just going to ask once and advise once. You're going to ask and advise every time someone comes in. And what we find is that there's a magic. If you don't ask every time, you're missing the magic moment of change and motivation that folks have, where for whatever reason, and you can delve into that when you're assessing, this person is ready and you caught them. And it might be as simple as saying, hey, doc, I'm so tired of you asking me about quitting that I'm just going to do it. But that's why it's critical that you're asking it every visit and really documenting that. And so going back to the 2 A's and R, for the referral, really one of your best referral sources is your quit line. So every state has a quit line, and hopefully lots of you are already working with your quit line. The nice thing is that you can, if you're in any state, you can call 1-800-QUIT-NOW, and they will connect you to your local or your state quit line. A lot of states also have numbers for their states, but you're going to the same folks. So it doesn't matter if you use the 1-800-QUIT-NOW or the local number that you might find on your web pages and so forth. And so the quit lines have been doing an amazing job. They're just extraordinarily adept at doing counseling, so the behavioral piece. Most offer anywhere from 2 to 5 counseling sessions per treatment. And sometimes they will do two sessions or 2 regimens per year, but it's typically about 2 to 5 calls. In most of the states, it really is dependent on the state budgets, but most states offer some form of nicotine replacement therapy or other medications for some amount of time. So it could be 2 weeks, it could be 5 weeks, it could be 8 weeks. It really is budget driven. But what I highly, highly recommend is that you use this resource because these are free to those who call in. So both on the medication side and the counseling side, in many cases, it's going to be free to your patients. Unfortunately, here's the downside, not the downside, just the reality of quit lines, is that we know how effective this is. So again, if you're calling a quit line, you're getting medications, you're doing the counseling, the quit rates are as high as 30%. Actually, that's about the average of quit lines nationally. But the reach isn't great. So we know that among all the smokers out there, quit lines are only reaching less than 1% of smokers. So we have this evidence-based practice that we know that works, and somehow we need to do a better job of driving even the highest risk folks to the quit line. We know, for instance, that on the behavioral health side that anywhere from 50% on the low end, if you're going to be really low, 40% to 80% of the callers to any state quit line have a behavioral health condition. So it is really these very at-risk folks that are calling the quit lines and asking for assistance. And so as a provider, you can make contact with your quit line. They make it extremely easy to refer folks to your state quit line. And where we're going in the future is e-referral. So when you get your EHRs set up or your EMRs, you can refer through, there's a lot of pilots going on, that you can do the e-referral through those systems and get that bi-directional feedback about what is going on with your patients after you refer them to the quit line. So really, really nice resource. But in addition, like I said, outside of the quit line, you really want to look at what other sources are out there. Often there might be a behavioral health setting that you are partnering with, and they're running tobacco cessation groups, as one example. There are nicotine anonymous groups out in the community that are another value add. Basically, you want to throw as many resources as possible at these smokers or tobacco users at any given time. And so one of the models that Jim mentioned and is one of the sessions is upcoming is really looking at motivational interviewing and how that fits into this and how can we really encourage meet folks where they're at, meet the patients where they're at in their readiness for change, but then also use motivational interviewing strategies to really um, help them get motivated for change. And so we'll talk much more about where you do that in the series of 5As. You might actually do that more in the advise as well as assess. That's in the green here, and then where to go from there. So the next A is assess. So if you move through the ask and advise, and you want to get a sense of how to treat these individuals, then you need more information, just like, again, any other medical condition. So initially, how you can do this is just to ask more clarifying questions about how individuals feel about their smoking. Why are they talking about it now? Have they considered quitting in the past? Really what's gotten in the way? I mean, this is where you really want to go with this, because most of the folks that have tried to quit multiple times. You've probably heard many of those numbers, that it takes X number of quit attempts before people actually quit. And we don't really highlight those numbers because it's not extremely motivating if you tell people they have 8 more attempts possibly to quit, because the average is 10 attempts to actually quit. So you don't really want to go there, but you really do want to explore the barriers to quitting. So what got in the way in the past? A lot of, some of the typical things that we hear is that folks tried nicotine replacement therapy. It didn't work for them. Well, what we're going to get into in the pharmacology section is we probably weren't prescribing right. In many of those cases, we were probably incredibly underdosing NRT, and it's not effective if it is underdosed. But they could be living with smokers. There could be stressful situations that happen. So it's really exploring what worked. So maybe something worked for a period of time, and what didn't work, and what got in the way. And then you want to get into really assessing what their dependence level is. And so that's looking at how much are they smoking, what is the frequency, how long have they been smoking, and you can get into their stage of change too, their readiness for change. Are they contemplating change, or not quite there? They're pre-contemplators, and so forth. And so one of the easiest ways to do this, and it's really when we get to the workflow section of this, the Build a Clinic series, there's one that's specifically targeting workflow. You'll figure out, we can walk through kind of, you might be an office of 1, you might be an office of 5, it might be interdisciplinary and so forth. And so it's really important to look at your workflow and who's doing what. And if you're going to be assessing, how can you do that? Who's going to be doing it, etc. So again, we're creating the lowest impact and really building this into what's already happening in your clinic, so that we're not putting tobacco in a silo. That's the biggest mistake that a lot of sites make. And it's really just building this into what you're already doing. That said, there's some extremely well validated measures out there that look at tobacco dependence. Probably the most famous is the Fagerstrom test for nicotine dependence. You're seeing it here. So it's the 6 questions you're seeing on your screen. Very easy to give, very easy to score. It gives you a real sense of nicotine dependence. But in the blue, what you're seeing is the heavy smoking index. So these are just 2 questions, a subset of the Fagerstrom. And these, what we found, what the research is finding is these are the 2 most important questions out of the 6. So if you really were time limited, you would maybe want to ask just these 2 questions. how soon after you wake do you smoke? And if people are rolling out of bed and the first thing they're doing is smoking, we know they're incredibly nicotine dependent. How many cigarettes do you smoke a day? Well, again, if you're a 2 to 3, we often work with 2 to 3 pack smokers. That's much different than if someone is smoking 2 to 3 cigarettes a day. And that's going to have huge implications for how you treat and how you dose, both counseling and pharmacotherapy. And there are other objective measures too that you want to consider. So you want to consider using a carbon monoxide monitor. The other measure is the cotinine level assessment. So we'll talk about both of those real quick. So carbon monoxide is just looking at when people are breathing into the monitor, how much carbon monoxide is in their system. And it's a really nice measure. We're going to talk about that in the next slide. Cotinine is the other assessment that's out there. You have a slide later on for that? Yeah, so cotinine, you can test that. It's a metabolite of nicotine that stays in your system longer. So if you're really trying to get a true sense of if someone has nicotine metabolites in their system, this is the way to go rather than carbon monoxide. You can do that through urine. You can do that through saliva, blood, etc., hair samples. So there's a variety of ways that you can collect nicotine. But really, what we highly recommend is using the CO monitors. They're very non-invasive, and really using these as motivational tools more than anything else, and not paying a lot of credence to the numbers, but really it helps folks realize how impactful this is to their health. And as you're treating over time, it gives them a great sense of achievement if those numbers are going down. Very easy to use instrument in a clinic setting. And then you want to assist folks with their smoking. So we're getting into the fourth A, and so that's helping them, through their treatment planning, to possibly set a quit date or gradually cut down. Cutting down, until they get to 10 or less cigarettes might be a great strategy, and then set that quit date. Or they might be motivated to set a quit date right away. But again, discussing their concerns around that, encouraging social support as well. Of course, there's going to be people that aren't ready to change. A lot of these folks have been feeling pretty hopeless and helpless about their tobacco use because it's been with them a very long time. They started it in their teenage years, and they've had an extremely hard time quitting, even when they've tried. So their motivation may be kind of low just based on that. And they might feel very unsupported by the others in their lives as well. Are stigmatized in their social networks, such as in the behavioral health world. That's a lot of the work we do. Just feeling like the stigma goes two ways. Often you're stigmatized if you smoke, but often in some cultures you're also stigmatized if you don't smoke. So really looking at what are the contextual factors that these individuals have to face. But even if people aren't ready to change, and that's really where we get into the motivational interviewing strategies and so forth, almost everyone is willing to do something. So they're willing to at least read handouts, gather some more information. They're willing for you to continue the discussion if you approach them, asking permission if you can continue that discussion with them over time. You can help them keep track of their current tobacco use. That's an excellent strategy. So not saying you have to quit, but looking at strategies for saying we just track how you're using, when you're using, what are the events going on around you when you are using, and then thinking about the benefits of quitting smoking. And we find that almost everyone is willing to do some level of this, even if they're fairly resistant to saying they're going to quit smoking right now. And then you want to arrange, so that's our fifth A, and making sure that you're bringing folks back in and through the follow-up visits. We know that if you are following up, that folks are more likely to follow through with their goals. But also to be very cognizant of making it clear early in building the rapport around this, that even if people aren't successful in their quit attempts, you really want them to come back and discuss what happened. If people no-show for your arranged follow-up, that's probably a good sign that they relapsed, and you really want to try to get in front of that and be proactive and say, this is hard. Barriers might come up. You might not be successful. Come on back, let's discuss what happened. This is a learning process. This is an iterative process, and really congratulate any successes that happen. I mean, if someone moved from a pack-a-day smoker to 15 cigarettes a day. I mean, that is an incredible success. And everything we're talking about is laid out, and there's a wide variety of nice resources for you. So if you go to this link at the bottom, we're going to post this webinar as well and archive it on our website, so you have all this. So if you miss any of the links and so forth, you can go back and see it. But if you go to www.bhwellness.org, we have a tremendous amount of resources, and we have the toolkits for healthcare providers, and then we have supplements for various populations that are at high risk as well. And this, in much more depth than we're talking about today, really goes through the 5 A's. It starts to talk about the pharmacology and so forth. So I highly recommend that you grab this and talk about that. And at this point, I'm going to turn it over to Jim for the last few minutes just to talk about some other resources to consider.
Thank you, Chad. The Behavioral Health and Wellness Program is proud to be one of the 3 partners providing network support, content, and program evaluation services for the National Behavioral Health Network for Tobacco Control and Cancer, a CDC-funded effort to reduce disparities in health outcomes in the behavioral health community in these 2 areas. Today, the National Behavioral Health Network has officially launched a request for applications for 2 new CDC-funded communities of practice. One is designed to provide support to community behavioral health organizations, so if that applies to you, that would be the RFA you'd want to look at. And the other is for state, tribal, and territorial agencies, either of one of which is seeking to develop or enhance their tobacco and cancer control prevention efforts for people with mental illnesses and substance abuse disorders. This will be our 2nd year providing content and technical support for NBHN, and we're very excited about today's announcement. If this sounds like something you would like to hear more about, please send us an email, which will show us up at the end, and I'll fill you in on the details.
Do you want to, Jim, just tell them a little bit about just the resources in general if you join the national?
Yeah, so the National Behavioral Health Network, you don't have to join the community of practice, you don't have to apply for that, but you can actually join the National Behavioral Health Network by itself, and through the National Council on Behavioral Health, there's just a constant stream of high quality webinars and instructional materials coming out of that organization all the time. And we can also, that organization can also link you to other national organizations, like the Smoking Cessation Leadership Council out of UCSF. Do we want to go?
You know, another organization that we would recommend that you take a look at is ATTUDE. So it's the Association for the Treatment of Tobacco Use and Dependence. A long wordy, so we just say ATTUDE. But it's really an organization of tobacco cessation providers that is interdisciplinary. Many of these folks are working in hospital and primary care settings, behavioral health settings, corporate settings even. And these are just the specialists. And so it's a great organization if you have folks that are really going to specialize in tobacco to become members. So it's a great clearinghouse of, again, lots of great resources, lots of great back and forth and blogs and so forth. And there's probably about, right now, over 40 disciplines that are represented by ATTUDE. And the last thing we'd like to point out is that if you're getting into this world and integrating tobacco cessation into your practice, it's really helpful, again, to have experts on hand. So one way to do that is to get folks into TTS, some of your staff, it could be you, into the Tobacco Treatment Specialist certification programs. There's 13 nationally. I believe it's up to 13. And so we are one of those. Ours is called the Rocky Mountain Tobacco Treatment Specialist Certification, but there's great programs around the nation. And so this is, for us, it's an interactive 4-day training where folks get certified to be a tobacco treatment specialist. And why that's important is that really where we see is that this is going to, in your workflow, your sustainability, scalability, is that increasingly TTSs hopefully will be able to bill within your settings also. So the save the date, our next one, if you would like to join us for this, is in May 16th to the 19th. And again, you would just go to our website for more information about that.
As I've already mentioned, today's presentation was designed as the public portion of an intense 6-month learning community. In addition to the 6 public webinars already discussed, the Build a Clinic program engages practices staff in 6 exclusive live collaborative sessions with up to 15 practices around the country using the innovative eco-distance learning model. It also engages those practices in 3 individualized technical assistance calls. The webinars, echo sessions, and TA calls all benefit greatly from the support of Echo Colorado's crack team of educators and the expertise of the University of Colorado's Department of Family Medicine. Doctors Matt Simpson, MD, Chandra Brown-Levy, PhD, and Liz Wilson, PharmD, are all highly knowledgeable about the challenges practices face in the field as they attempt to accommodate these well-known clinical best practices for top-notch care. Please email us if you are interested in potentially joining future sessions.
All participants have been unmuted.
Okay, so at this point, we have, if you would like to, we'd love to entertain any questions, comments. So if you would like to do so, just make sure you unmute yourself. So just hit *6* again and chime in. And again, just remember, if you'd like to say anything, just make sure that you're hitting *6* so you're unmuted.
Hey, Chad and Dr. Morris, I'm sorry, and Jim.
Sure.
Up to the Amy Adams with Full Vista Health, we had a question here about whether the statistics that you shared include vaping.
The statistics about nicotine use, or which ones?
The very first statistic, I think, about use
No.
over time.
No.
So that's focused on mostly cigarettes.
Yeah,
right?
yeah, exactly. So that's combustibles. And we know that the vaping, of course, is incredibly, we can do a whole presentation on ENDS, electronic nicotine devices, and vaping. But the most concerning part of that is that we've seen within 1 year's time a 3-fold increase of youth using those products.
But just to add to that, there is some research coming out that NRT is a successful option for treating people who have moved their nicotine dependence from traditional tobacco products to the e-cigs and other vaping products. And so if somebody is willing to move from vaping to something else, the same strategies that we talked about today can be used for them as well.
Mm-hmm.
Thank you. Hello.
Hi.
Hello. Hi. My name is Tanya Hernandez. I'm a clinical social worker in New York. And I have 2 questions.
Sure.
What are the side effects of the electric cigarette? Are
Mm-hmm.
they similar to the regular cigarettes with the nicotine level? And the other question is, the seminars that you posted from May 16 to 19 says 2015. I was wondering if the dates have changed for this year, 2016.
Yes. So if it did say 2015, I don't know where that was, but those would be for 2016.
Oh, okay.
But then to your, the issue with e-cigs and other vaping devices and so forth is that it's really hard to determine what level of nicotine these folks are getting. But if they are getting the same levels, most people know their dependence level, so they're going to smoke or vape to the, until they reach that level. So the side effects of now are you talking about the side effects of quitting or just the side effects of using?
No, the side effects of actually smoking that kind of cigarettes. I was wondering if it's the same as a normal cigarette.
Well, so, I mean, there are repercussions to. I mean, maybe do you want to talk to that, Jim, a little bit?
So a lot of when we think about side effects specifically to a lot of the smoking, it's a lot of it's due to the other toxins that are in the combusted plant material. And so there's this belief out there, this myth that e-cigs, because they're supposedly breathing in a productless vapor, has none of those specific side effects. But what we are seeing is that people are reporting a lot of lung irritation, and they do have a lot of. Yeah, you want to do that?
Yeah, for those of you that aren't speaking, if you can mute your line, *6*.
Thanks.
Yep.
Yeah, so they are reporting. We are seeing some actual evidence of lung irritation, and they are users are reporting increased coughing episodes, and burning sensations. A lot of times, irritation in the throat. And there's such a small pool of users who have been able to come into, say, clinical trials that we don't have. We don't necessarily know what in the e-cig is causing that. If it's a product of the propylene glycol they're taking in, or if it's the vaporized nicotine, we're not exactly sure. But there are some immediately physical side effects, and then in terms of dependence, the dependence is equivalent depending on the level of nicotine they're taking in.
Oh, that's very interesting. I didn't know that. No, thank you.
You're
Last
welcome.
one question. Some of us clinicians have to complete CME courses in terms for licensing. Is any of these programs can be applied credit CME credits?
Potentially. Now, what is your specialty?
I'm a clinical social worker.
We could check in on that. There are some instances where if you take basically let it be known that you went through this training, that you can apply that to CEs. If you have questions about that, you could email us as well, and we'll look into it.
I'll do that.
Yeah.
Thank you.
You're welcome. Thank you.
What is the frequency of the next seminar? When would that be? Next month?
When is it, Jim? The next one?
April 12th.
April 12th.
Okay.
Same time.
Thank you.
Yeah. You're welcome.
Bye.
And I heard someone else.
Yes. Hi, this is Zim McCauley. I'm calling from Eastern State Hospital.
Hi.
Thank you, Dr. Morris, for such a really good beginning in terms of the presentation.
Thanks.
And I was quite intrigued by one statement you made about using the quit line. At Eastern State Hospital, we have primarily a behavioral health population.
Right.
And we found that to correct the reach in terms of using the quit line is a bit limited. But one of the things is because many of them may not have phones.
Right.
And if they do have phones, they may have restricted limits, which
That's right.
they probably wouldn't want to spend on the counseling. So in your experience, is there any way that we can help these populations to access this evidence-based?
Yeah, we actually that's an excellent question. We actually looked at that fairly closely. We're contracted to do that for National Jewish Health, that runs about 14 states quit lines. You're absolutely right on that. Folks that have limited minutes on their cell phones, they might not have a cell phone. It can definitely get in the way. And so some of the strategies, and Jim can share this too, is that clinics can set up, some clinics have just set up capacity for their clients to use their phones, and you can often set up the calls around that so that while they're on site, they might be able to use the telephones in clinics and practices. Jim, do you have other?
Yeah, so I think that Chad's right on. I think that the first thing, because it's the easiest, is if you can do it, setting up a phone station that clients can use or patients can use while they're receiving their counseling or immediately afterward. And especially for this population, that ends up being really beneficial, because there's always an intake call, and that can take up to 30 or 40 minutes. And then they get their first counseling call afterward, which can be another 30 or 40 minutes. So being able to set them up for those expectations proves to be one of the first hurdles that they need to get over. The second thing to do, and this is a little bit more complicated. Hi, if you're not speaking, can you please mute your phone? Thank you. If you have the wherewithal, if you have the resources to reach out to the community to find out where your behavioral health population lives and interacts with the rest of your other community members, with that, whether that's in a Salvation Army or a church group, of like a soup kitchen, something like that, and try to set up, see if they will volunteer their own phones for sending or giving, for dialing out and receiving those phone calls. Bruce Christensen at the University of Wisconsin has been doing a lot of work in that regard, and they've had quite a bit of success doing that.
Okay, well, thank you.
You're welcome. So we have time for one or two more questions. Okay. Well, hearing none at this time. Again, we very much appreciate you joining us. We hope you continue on and join us for the rest of the modules. I think that you'll find they're very well linked, and we'll just go much more in depth in some of these areas. So with that, let's go ahead and end. And thank you very much, and enjoy the rest of your day.